All right,
Okay.
fellows, welcome to the webinar. Hans Lee from Baltimore, and today I have maybe a familiar face from our last webinar. I have Raj Desai here from the Chicago Chest Center. He is also working very closely with CHEST and the American Medical Association on a lot of these coding and billing. So this is a real treat and a topic that, boy, I wish someone had talked to me before I went into practice, but go ahead.
Yeah, thanks for having me. I'm very impressed and commend ACCP and Dr. Lee. That they have actually put this topic, which is so important. I mean, during our fellowship, we learn about medical training, clinical knowledge, but really there's not much education in terms of coding and reimbursement as well.
Yeah, I just want to mention again that this is a joint program between CHEST and Medtronic. So this program really is for the pulmonary fellows, for you guys, just to kind of give you that help when you start out. So let's go ahead and move forward with some of the slides. And I think, from our last meeting at CHEST, terminology was a big issue. I think a lot of people didn't know what RVU actually stood for. When I was starting out, I couldn't even spell RVU. So maybe you can give us a little background.
Yeah, I think it's so important. I think to understand the terminology, and one of the most common terminologies that we use is RVU, which essentially is the amount of work that we do, and there is a value assigned to it. It is a relative value unit. For example, if Dr. Lee, Hans did X amount of work in Baltimore, it would be similar across the country, and it would be similar in Chicago. So that's how we would look at it. For example, if he saw a patient in the clinic and he evaluated the patient for the first time, came up with a plan, and that amount of work would be similar if that was done in Chicago as well. So that's really the basis of relative value unit. Now, it's very important because for us, as physicians, we actually are assessed in some centers. Actually, most centers now are going towards RVU work. That's how they look at what a physician is doing, and that is amount of work that we do. Why does it matter? Because a lot of institutions are actually paying their physicians to meet a minimum amount of work RVUs, and then if you go over that number, there's actually incentive or bonus associated with that as well.
So we can make more money sometimes.
Yes.
So it's really important. So it sounds like RVU is just a metric of how much we're actually working or being productive. And
right.
More is better than less.
Yes, and I think for the physician and for the institution as well. Now, you have to be always careful in terms of what your benchmarks are, in terms of how much you have to meet, at least the minimum amount of RVUs that you have to meet.
Right.
So that varies from institution to institution and region as well. But one of the, I would say the ballpark that we have seen across the country is at least, 5,500 to 6,500, anywhere between that as a minimum.
So maybe about 5,000, maybe 6,000, depending on your practice, private or academic. That's what you're generating per year? Is that
yes.
Per year?
Per year.
Okay.
Yeah.
All right. So really important term to understand. And what are these other terms that we have on this slide, and how are they associated with RVUs?
Yeah, I think so. Some of the terminology that, as a practicing physician, you should know is E&M, ICD-10, and CPT. E&M stands for evaluation and management, and really this is the amount of work or the type of work that you did. For example, seeing a patient with lung nodule and spending 30 minutes, and this was an initial consultation for the lung nodule, there would be a separate evaluation and management code for that. Now, for that same patient, if you look at what diagnosis that you would use, that would be a lung nodule. And that actually you have an ICD-10 code for that. And so simply, there's a code for each diagnosis that you use. And if you decided to do a bronchoscopy and you actually evaluated a patient by doing a bronchoscopy where you did a biopsy, there are codes for that, and that's called CPT code. So essentially, those are the procedural codes for.
So CPT codes, procedures, ICD-10, some sort of disease, pneumonia, lung cancer, pulmonary nodule. Gotcha. Okay, good to know that we have that terminology in the background. And so we can move on to our next slide. And so these are some what commonly used E&M codes. Can you kind of take us through it? It looks like there's some complexity associated with this.
Yeah, and so every level of service that we provide has an E&M code to that, and it's all based on the time we spend with the patient, the complexity of the case as well. For example, if a patient has multiple medical problems, you have actually gone through a very complex history, has history of family history of lung cancer, and you're actually reviewing their images and spending 45 minutes of your time, then you would actually bill at the highest complexity level in that situation. So
higher complexity, more RVUs, and give us an idea of what is 99223 high complexity for initial hospital consultation. What does that equal to in a RVU world?
So approximately, 3.8 to close to 4 RVUs that you would see, and that is actually the highest complexity in an inpatient setting. Now, there are two ways to look at this. Number one is, when you see a patient the first time, that is an initial contact or initial consult with the patient, or it could be an initial H&P. You could be, that patient would be admitted to your primary, so you would be the primary physician taking care of that. And that is the initial contact with the patient. And if you see the patient the following day, for example, and that would be considered as a subsequent hospital care or follow-up visit, for that. So that also is broken down into complexity as well. But I think to your point, a 99223 would be a patient that you're seeing the first time, a very complex patient, and the RV would be approximately 4, in that situation.
So just a little bit under 4.
Yeah.
Probably get more RVUs for initial visit because you're probably asking more questions, looking at more data. And then the subsequent care, maybe a little bit less because you already gotten to know the patient.
Right.
And we should probably document complexity, or we can write how much time we've directly spent with the patient. I know sometimes in my notes I spend at least 45 minutes in direct patient care. Does that count? Or?
Absolutely. I think it is so important to document that, you need to document that you have actually done the work, right? I think, we all know that we have spent a lot of time. I think you have to be very clear in your documentations, making sure that you actually spell it out. If you're spending 45 minutes with your patient, you need to find a way in your note that you mentioned that I've spent 45 minutes. Now, obviously, it has to go along with the work that you have done.
Right.
You can't just, for a lung nodule, that was a 2-millimeter lung nodule, and the patient had no other medical problems. You can't spend, 45 minutes with that patient unless there are some extenuating circumstances in there. But you have to then spell it out that you actually spend 45 minutes in coordination of care and what have you in that. That said, having a clear documentation and a comprehensive documentation is the key to making sure that you actually are billing appropriately. Because as as we all do, when we do something, we realize that, we have done more than what we actually thought we did. And you actually spell it out, you'll be able to bill higher and appropriately for that patient.
Right. So if I review the chest CT scan images, or I've discussed these findings with my referring doctor, or maybe follow the shared decision patient making, discussing the risks and benefits of either doing a biopsy or a subsequent CT scan, all of that counts towards complexity, and I should document that.
Absolutely. I think sometimes, it's also helpful if you are seeing patients with lung nodules routinely. developing your own template, for that. For example, I personally use, few phrases that I see, because most of the, every patient that I see with lung nodule, I will be reviewing their CT. So I have a template that just simply says, or dot phrase, radiology personally reviewed and compared to the previous imaging if they have.
Right. Perfect. All right. Let's look at the next slide. And I believe the next slide also talks a little bit more about EM coding, but this is more for outpatient care. So there is a different code for outpatient care and inpatient care, but they're also arranged in low to high complexity. And give us an idea of what the RVUs is for, like maybe the highest level of outpatient new care, this 99205.
I think, again, a little under on the 4 is the RVU that you would get in the highest level of care. That said, I think, as you rightly pointed out, I think, it's very important to remember that, there are 2 separate codes. One for an outpatient setting, one for or sets of codes for inpatient setting and for outpatient setting. And then within that, you divide it into new patient and subsequent care. So, and again, the concept, I think the most important concept to remember in this is higher the complexity, higher the code. And in this setting, the higher the number as well. And if you look at it, the level 5 or 1, is probably the highest, is the highest code, but has the highest complexity.
Right.
So with that, if you're billing for highest complexity case, and if you have done the work for that, then it's very, very important, and I can't lay more stress to document it appropriately.
Right. And the reason why we say level 5 or 4 is that if you notice that the last number on these codes is a 5 or 4, and they just coincide with higher complexity.
Yes.
All right, let's look at other slides and change our gears from EM codes to ICD-10 codes. And this looks like diseases, lung nodules, and it seems there's probably one for every disease, I imagine, that's out there.
Yeah, there is. And so it's International Classification of Disease, and this is the 10th edition of the codes. Internationally, everyone uses the same language. US was a little behind in terms of implementing these codes, a couple of years behind others. But the important thing is that, lung nodule, if you just put in lung nodule, the person who is helping you with the billing, that's the coder, doesn't recognize that diagnosis. What they do recognize is the ICD-10 code. And so that's why it's very important to put in these diagnoses and associate the ICD-10 code with that. Usually in most of the EMRs, these codes are associated and inbuilt. Every EMR, if you're, and most institutions now have electronic medical records where ICD-10 codes are linked to these diagnoses as well. For example, in this case, if you see a patient with lung nodule, you've done your evaluation and management, you came up with an assessment, and when you're putting in your assessment, you put in a problem list. And the problem that you've addressed during your visit would be a lung nodule. And so you would enter lung nodule, solitary pulmonary nodule, if there's only one lung nodule, and the ICD-10 code for that would be R91.9.
Yeah, so we have Epic as our EMR system at Johns Hopkins. And so I have to put in an EM code, right? Tell them how complex the visit was. I got to tell my coder and billers what I saw them. So a pulmonary nodule, either multiple nodules or lung nodules. So I got to put in something for an ICD-10 code, usually a drop-down menu. And but what if I do a procedure? Maybe let's look at the next slide. I think that takes us into our CPT coding. And so what are these? What is CPT exactly? Is that a different code that I have to do now? Or?
Yeah, I think so. So it is, this is where it gets a little complicated. Now you have evaluated the patient, you decided that you want to do a procedure, a bronchoscopy, and now you bring the patient in and you do a bronchoscopy. Now, if you do a simple basic bronchoscopy where you have gone in, you evaluated, and you actually did washing, then that would be a 31622. That's a CPT code. So that's the code that is used for bronchoscopy with washing. And the associated RVU with that would be 2.53. That means the work or the value of the work that you did in doing a basic bronchoscopy is 2.53. Now, if you go ahead and do brushing, lavage, and a biopsy, then there are different RVU code, different CPT codes for that as well. It gets a little complicated in terms of the RVU, and in the next few slides, we will go over how that will affect your, total reimbursement for a procedure.
I see. So the maybe the average starting requirement is about 5,000, 6,000 RVUs, and so we get maybe a little less than 4 for a high complex new visit in the outpatient using that EM code that we talked about.
Right.
And here we have the work RVUs for bronchoscopy. So it sounds like we have to do quite a bit.
You have to do quite a bit.
Okay. All right, let's look at the next slide, which has additional CPT codes. But I noticed here, Raj, the work RVUs are actually a little bit higher than we saw on the last last slide. Why is that? Why are these a little bit higher?
That's a great observation, Hans. I think so. Once we start adding complexity to our procedures, so we also need to realize that these value units are associated with the amount of work that you do, and also the complexity of the encounter or the procedure. For example, in this scenario, when you look at the first code, which is the 31652, which is bronchoscopy with endobronchial ultrasound, it is more complicated and takes more time to do EBUS compared to a basic bronchoscopy, and that's why you see the differences in the work RVUs. On basic bronchoscopy had approximately 2.5, and this has approximately 4.5 work RVU or relative value units associated with that. It's important to realize that if you are sampling 1 or 2 lymph nodes, there is a code for that. Anything more than or equal to 3 lymph nodes, there is a separate code for that as well.
I see. All right, that's good to know. So we know about EM codes, ICD-10 codes, and CPT codes are for procedures. Let's go on to the next slide and talk a little bit more about something called documentation. You wrote it 4 times. Must be really important. We talked a little bit about it. So Raj, let me ask you, if I just bill everything at the highest complexity and I don't document, or justify, what I'm doing, is that wrong? Is that fraud? Is that
Yes, it is, and I think, and it's something that you should not do. Obviously, I think just like what we learned in our med school, right? I think we learned it from day one. We need to document. We need to get good history, and we have to carry forward. When we are in practice as well, make sure that we are documenting all the things that we are doing with the patient. We all spend time talking to the patient, getting the history. Make sure you're documenting that. Put in all the review of system, physical examination findings that you have done, and have a very thorough assessment and plan along with that. Now, when we do procedures, it is very important to actually document that you had all these conversations with the patient, including the reasoning why you're doing the procedure. You want to make sure that is included. At the same time, you have talked about the alternatives, and we have realized in certain procedures that insurance and the payers, they still might consider your procedure as something which they may not want to reimburse. So they need clear justification that this is actually a superior procedure, right, and a less invasive procedure. In our example, EBUS, we faced a lot of challenges initially justifying EBUS as a procedure, because the payers actually were not well aware of EBUS. They thought mediastinoscopy was the gold standard. Mm-hmm. So we had to actually include in our note saying that EBUS is less invasive and superior and there is evidence,
Right.
that goes along
Yeah.
with that, and you have to clearly document in your notes.
Yeah.
And also when we're doing the procedure, you document it in operative notes. I think, most of us, will document twice, things. It's better to be a little redundant in this situation.
Yeah, over communicate and under communicate. I mean, they just can't read my mind about from these coding and billers and payers that they don't already know. I mean, it sounds like we already do all this work. We ask the family history. Hey, do you have lung cancer in your family? Do you smoke? Where do you live? All of these factors, which I think maybe we take for granted that these people aren't aware of. Sometimes we do have to spell it out. We do the work. We might as well get the credit by documentation and then properly putting in the associated EM or CPT codes. So.
A couple of points that I wanted to highlight in this on this slide was, when you're documenting a procedure in an op note, make sure you are documenting the laterality, where you were. For example, you are in the right lower lobe. Make sure that you're in the right lower lobe and appropriate location. If you're in the superior segment, also better to specify that. If you did biopsy from right upper lobe and right lower lobe, then make sure that you are documenting that as well, because actually there's a separate code for that as well. If you document, if you do procedures from two separate sites, and again, obviously clinically it's very important, but from the documentation standpoint, the type of procedure that you did and the type of specimen that you have taken in a manner that can be easily communicated to the coders as well.
I see. So the coder and billers who get my note and my billing codes are not mind readers and they're not physicians. So sometimes we have to spell it out for them with these codes. Let's go on to the next slide. And I think we're going to talk about my favorite topic, reimbursement. This is how I can afford not to live month to month on my fellow salary. And now I'm not a fellow anymore. But tell us more about reimbursement. I'm getting all excited now.
Yeah, reimbursement is really very exciting. That said, one of the things that you always want to remember is that the reimbursement is always subject to changes and updates. So your reimbursement historically, we have seen go down for a procedure. I think that's the bad news, bad part of that. But it does update and change. So you have to be updated, or you have to know what the reimbursement is there in your region as well. There are two components to that. When you get reimbursed, for example, if you do a bronchoscopy, it's the technical fees where the hospital gets reimbursed, for the work that you did or the work for the procedure, and the professional component, the bronchoscopist or the physician, part of the reimbursement.
I see. And there's two components also for outpatient consultations and inpatient consultations. And let me ask you, who usually gets more money, the professional, meaning me, or the technical hospital or practice?
I think we wish, right? I think it was the physicians, but the hospital definitely gets more money, and they obviously there are a lot of resources that are spent as well during the procedure.
Yeah, so there's a lot of cost. They have to pay for the electricity, the cleaning person, the building, the rent. So they have higher costs, and so a bigger chunk of the reimbursement goes to them, and some of it does come to us directly. Okay, it doesn't make a difference whether you're employed by the hospital or you're in a private practice group. Is there some differences there? Or?
No, I think in terms of reimbursement, you're looking at a relative value unit. So that's similar across the board.
So that's why we use the RVU system. Got it.
Now, the important point to note is that the reimbursement does matter, or based on the efficiency and how good your coding and billing team is. And the way as physicians we can help our coders and billing is, again, going back to the same concept of documentation and having a clear communication of how the coders can actually interpret those procedures.
I see. So just more accuracy.
Yeah.
Okay, let's go on to the next slide. which talks about, I think, people's least favorite rule. Tell us about the multiple endoscopy reduction rule.
Yeah, I think so. So we talked about, and I think I see that the slides actually getting a little grimmer and grimmer, right, as we progress through this. But I think the important thing is that we remember that we are getting reimbursed now. And if we do a lot of procedures, for example, if we do a bronchoscopy and then add on a brushing plus a biopsy or a bronchoalveolar lavage, that doesn't mean that all these procedures are going to be added for reimbursement. That
so I don't get credit for a lavage and a brush and a EBUS. I don't get the whole sum of all three of those together.
Exactly.
Even though I do all three of them together.
Right. We would imagine, right? I think so. We don't get the sum of this, and the reason why that doesn't happen is because you cannot do a brush without putting in a bronchoscope. Correct. So that's why it's all inbuilt in the bronchoscopy procedure, and there is a rule that actually comes up with the sum that we would get, and that's called multiple endoscopy. And as you can see appropriately, or you can see it actually reduces the value of the total sum that you would get based on a formula. And I think we're going to go over a couple of slides.
Let's take a look at some of those examples
a little later.
Look at the next slide here. And here we have modifiers. Boy, I wish somebody would have told me about modifiers going into practice after fellowship. I honestly, to be honest with you, didn't really understand modifiers until I would say beyond a year after starting. And tell me about modifiers, because this is another part I get excited about too, because brings some fairness into what we do.
Right. And so, modifiers are really in addition to what you have already done. For example, if you do a bronchoscopy and you find a lot of bleeding, and there is a hemoptysis, and you are actually spending a lot of time in there with suctioning the clots and making sure that the patient is stable, localizing the site of bleeding. Now, if we do an intervention, there are codes for that. But if we just stopped at that, then this would be, in terms of coding, this would still be considered as the basic bronchoscopy. Now, but you did spend more than what you would do just by taking a look, right? You spend more time in this. So there's a code for that. So really, what the modifier 22 does, it actually helps with us. Unusual procedural services where the procedure was very difficult or time consuming, and you can actually use a modifier 22, which gives you about 20 to 25% more reimbursement for that. Now, the reimbursement is also dependent based on your region and your locale, and it varies. Some cases you actually have to appeal for it, but this is a code that can be used for those unusual procedural services.
Yeah. Tell us about modifier 25, because I think that's something that a lot of fellows could use, and that's something I use quite often because I do different types of procedures and I see patients, and sometimes they're in the same day.
No, I think just going back to your example of hemoptysis. Now, oftentimes we get consulted for a patient who has hemoptysis, and we go in and see the patient, and they need a same-day bronchoscopy. And so when you do that, you can actually use a modifier 25. And really, when you use modifier 25, is just to alert the coding and the payers that, hey, in addition to doing the procedure, and during the procedure, H&P is actually included. We have to do an H&P when we're doing a procedure. So this is outside of that. You're doing a consult outside of that regular bundled H&P.
I see. So if I see a patient and I figure out I'm talking to the patient and looking at the CAT scans, and I do a consultation for hemoptysis, and then I'm like, boy, this patient needs to get a bronchoscopy today or some other procedure, could be a thoracentesis. I'll get credit for the consultation with that EM code and also the procedure, right? The procedure code.
Correct.
But I got to add the modifier 25 to the EM code?
EM code. Yeah.
EM code.
Yeah.
So I would pick the initial consultation, high complexity code level 5, and then add modifier 25, and then add the procedural code. So I'll get
Right.
both credit for the procedure and the consultation. Now, if I don't use the modifier, what happens?
So if you don't use the modifier, for example, if the patient came in for a bronchoscopy, you you need to actually do H&P, and the payers actually realize that, you know what, this is part of your H&P, so they don't reimburse you for the additional E&M work that you have done.
So I don't get any of the credit if I don't use the modifier for taking the history, talking to the patient, discussing the alternatives and risk and benefits, and even if I documented everything, and then I don't use the modifier 25. Are you telling me I only get credit for one or the other?
Exactly, and I think that's but the caveat being is this is an initial visit, right? So this is oftentimes used in an inpatient setting where you get consulted for you get consulted for hemoptysis or something that needs to be taken care of. If you're seeing a patient as an outpatient, unless you decided to do same-day procedure, that would be an example that you can still use. But if you're seeing the patient a couple of days before, then this would still fall into a separate E&M code.
Yeah. So if I have a patient that comes into my office with a large pleural effusion for dyspnea, and I have a thoracentesis kit, and I do the thoracentesis right there and then to make the patient feel better the same day, this is where I should use the modifier 25 for the office visit for dyspnea, and then also for the thoracentesis coding.
Correct.
Okay.
And again, same physician on the same day of the procedure.
Perfect. So you guys learned about it before you graduated. I didn't, so that's really important. Now let's look at the next slide. Sedation. All my patients ask for this. Now there are codes attached with this, huh?
Yeah, I think so. One of the things that we have actually, over the years, bronchoscopy had moderate sedation. There was an inbuilt code with that, and now moderate sedation has been separated out from there. And this actually came about because a lot of bronchoscopies actually have now been done with anesthesia and what have you. So simply in terms of coding and billing, if you do a procedure that is under moderate sedation, there is a code for that. And so if you spend 15 minutes of time, there is a CPT code 99152, and anything more than for every 15 minutes more, you can actually bill for 99153 as well.
So this is on top of the actual procedural CPT code.
Correct.
I can also document my sedation services and the sedation codes as
correct.
well. So I get credit.
Correct. So for going back to that example of that patient with hemoptysis, if the patient had just you took about 15 minutes and you did moderate sedation for that patient, you would do 31622. Would be the basic bronchoscopy code, noting that this was not a very complicated procedure, and then you would add on to that 99152, which is the moderate sedation code. Now it's important to realize that that actually does give you some RVUs, so it's important for you to realize and document that if you're doing that service.
Right. Okay. So important to get the credit that you deserve because you're doing it, and RVUs are just ways of metrics of keeping track of how much you're doing. So if you don't document it and code it and bill appropriately, you may not get that credit.
Exactly.
Okay, let's look at the next slide here. We're learning a whole bunch about a lot of different things. Let's put it together, and why don't you take us through this example?
Yeah, I think this is where it gets very interesting and really exciting as well. Now think about this, and I think we talked about some scenarios where you're seeing the patient in your office, but let's go over this example. A 56-year-old man with a history of cough and is found to have a right lower lobe nodular density. The pulmonologist decides to do a bronchoscopy, and during which she performs an inspection of the airways, a bronchoalveolar lavage of the lateral segment of the right lower lobe, and 7 transbronchial biopsies randomly were taken from all the segments of the right lower lobe.
I think they're just trying to make things harder for you.
Yeah, and so, but I think so importantly, so what we did was we found an abnormality, and then bronchoscopy was performed. I think that was the clinical part of it. Now the coding part of it, what you did was you went in, you did transbronchial lung biopsy, you did an inspection and basic bronchoscopy, and you also did a lavage 31624. Now remember that when you as we had talked about earlier, that airway inspection, which is 31622 basic bronchoscopy, is always going to be included in anything that we do. So that's why we don't use that as a billing code when we are putting it in there. So when we look at that, so I think when you look at the CPT codes with the procedure that you did, it would be 31622, that was airway inspection. And if the payer, let's assume, would pay $150 if someone just did basic bronchoscopy.
And this is part one of 2 parts of that reimbursement that you talked about, the smaller part.
The smaller part. Exactly. Right. And so this is the professional fees, and that's a great point. This is not the technical fee for the hospital, but this is just the physician or professional fee for that. And then if you look at 31624, which is bronchoalveolar lavage, the professional fee would be, or the payer in this setting would pay $160. 31628, which is transbronchial lung biopsy, if the payer pays $190. And this can vary. I just picked up some numbers that can help us understand the concept. So there's a lot of assumptions with this. And if you go to the next slide. So if you apply multiple endoscopy rule, the formula changes on what we are going to get paid. Now, important to understand with multiple endoscopy reduction rule that
reduction being the key word.
Reduction being the key word. There is so a primary procedure, and the primary procedure is essentially the procedure that is the most complex, the most amount of work, or the most amount of RVUs associated with that. And that is paid fully. And then anything less than, or rest of the procedures are partially paid. And the way we calculate it is actually we subtract it from the base code 31622. And so in this setting, if you think about it, the most complex procedure that you did for this patient was the transbronchial lung biopsy. And you would use 31628 as your primary code, and that's going to be paid fully. So for this payer, if they paid $190 for the transbronchial biopsy, that's what we would get. And for the other procedure that we did, that was 31624, that was bronchoalveolar lavage, what you would do is you would actually subtract it from the base code 31622. And in this setting, the 31622 was $150.
I see.
And so if you go one slide back again, so here the base code was $150 and the bronchoalveolar lavage was $160. So there's a difference of $10. And you can go back to the next slide. And that's how you would get the $10 for the 31624. So the total reimbursement for the procedure would be $190 plus $10. That's $200.
Although this is a webinar, I can hear the jaws drop from our audience with getting the additional $10 for doing the BAL on top of the transbronchial biopsies.
Yeah.
I see, and that's why the key word here is reduction rule. You don't get you do get some additional credit, but you don't. It's not completely additive.
Not completely additive.
Okay, yeah. So good to know, and this really just applies for bronchoscopy.
Correct.
Okay, yeah. Perfect. So that's why it's important to also, if you're going to do an office visit or consultation the same day, to use that modifier 25 so that you also capture the credit for your consultation as well.
Yeah.
So let's look at the next slide here. And it's a real big thank you to Dr. Desai for spending this time with us. I know this is really, really complicated. Some of us are hearing about this for the first time. You know, any resources that you can suggest to get additional information, or in addition to rewatching this video?
Absolutely. I think, you know, obviously I'm available if you have any questions, and this is my email. You can always send me an email if you have any questions regarding coding and billing. A very useful resource that I found early on in my career was the Coding and Reimbursement book by ACCP. And we are in the process of updating some of those chapters as well. That's a very good resource. There are some useful resources from the AMA. There is RVU updates that come about every couple of years. That's a very useful resource to look at as well.
Yeah, when I started one of my first jobs, I got a little overwhelmed with all these terms and RVUs and EM codes and what the heck is complexity. So, you know, one of the things that I did was every time you start a new job, you usually have to, you know, attend some orientation regarding coding and billing. And I got the name and number of that person and asked that person if they don't mind spending some time with me on my first day of my job when I'm doing my coding and billing at the end of the day, to just kind of go over coding and billing as I coded and billing on the first day. And it was immensely helpful because it kind of put a lot of things together. And I didn't have like anybody teaching me how to do this during residency or during fellowship. And I didn't have a video like this either. So this was the time before YouTube. Yeah. So you know, don't be afraid to ask for help. And this was just meant to be an introduction, just for you to get some of the concepts down. And there's certainly a lot more to learn. I'm still learning. So I want to thank our audience. I want to thank you. I want to thank Chest and Medtronic for putting on this program. It's a program that I wish I had when I was a fellow. So thank you.
Thanks for having me.
Okay, that was perfect. It'll go through editing for the last few. I just touched something wrong. So that last part, it's going to go through editing.
Don't worry about it. Don't worry about it. All right, great.
Okay, thank you so much.
Yep. Thank you so much. Great. Thank you.
Have a great day. Thank you.
You too.
Bye-bye.
Oh,
how do I end it?